what I would like to do at this point is to shift gears and move on to targeted therapies, which are another exciting area in lung cancer. Individualized therapy is a reality for...
And you made a cornerstone presentation.
Thank you.
In the last 2 days.
We're going to talk about that. And let's start off with EGFR mutation positive disease. As you know, the prevalence of EGFR activating mutations is about 15 to 35%, depending on whether you're practicing in Europe, North America, or Asia. And we have at least 3 TKIs that are used in first line: erlotinib, gefitinib, and afatinib. Now we heard about the data with osimertinib. So I want to come to you, Marina, to get your thoughts on where you see the landscape changing and how this is going to affect practice moving forward.
So thank you. I'm quite embarrassed to present the results that you present in the plenary session, but anyway, it's a pleasure. So as you told us, we have now several EGFR tyrosine kinase inhibitors which are doing more or less the same, erlotinib, gefitinib, and afatinib, but they have a very different toxicity profile. And we have also several data coming from dacomitinib compared to gefitinib, which is the first trial which is superior to gefitinib. However, the drug is very toxic, and it's not very easy to do the drug to all patients in the clinical practice. You presented 2 days ago the FLORA study that was very expected by the scientific community, suggesting that osimertinib is much superior to gefitinib in terms of progression-free survival, and also a small benefit also in overall survival. So the final results are suggesting that the progression-free survival is almost 19 months. And the study before was done by the first or second generation EGFR tyrosine kinase inhibitors. Then we had to test for the presence of T790M on the blood or on the tissue. And we know that this is present in about 60% of cases. And for this kind of patients, we had to continue with osimertinib again, where the progression-free survival was almost 10 months and not 19 months as the first-line treatment. So now the choice is or to go first with osimertinib, which is a wonderful drug also for the toxicity profile, and to go for almost 2 years with this kind of drug, or again use the first generation TKI, then ask for the T790M and go with a third generation TKI. I think that the story is evolving. We have also to consider that there are trials ongoing combining together the first and second generation TKI with the anti-angiogenics, which can change again the scenario and put again osimertinib in second line. But personally, with 19 months of progression-free survival, I think that we have to ask to the patients what they really want and to tell that there are multiple strategies, but in my opinion, is quite a game over for in favor of osimertinib.
Thank you. Benjamin, your thoughts on the FLORA first-line study, osimertinib versus erlotinib, gefitinib?
Well, the PFS is clearly much better, and it's an easy strategy to start with osimertinib because you don't have to rebiopsy the patient, so it's easy. Because it's true that it's this rebiopsy, well, it's much better with the liquid biopsy, but it's something that takes time, energy, and there are probably 20% of the patients in which you can't rebiopsy the tissue because it's bone or it's too small. So it's the easy strategy, but yet I'm not sure it's the best strategy. I think at the moment, till I have the overall survival mature data of FLORA, I will continue with my current strategy, which is first generation or second generation, and then osimertinib. I have to say that for the uncommon EGFR mutation, exon 18, for example, my preferred choice will be a second generation inhibitor. And we will run at ERTC a study in which one arm will be osimertinib, one arm will be gefitinib, followed by osimertinib. And this kind of sequence study are really needed in the field to help us to understand which is the best strategy, because these patients live quite a long time. So it's not just giving a first-line treatment. It's really sequence all the treatments for the whole life of the patients.
The caveat there, of course, is not all the patients will develop T790, only half of them will develop, and that's really the issue when you think about what's the drug that goes first, because we don't have the ability at this time to predict who will develop T790 down the road. So, Giorgio, how do you view the FLORA data, and what does it mean for your patients on Monday morning next week?
Well, the study, as I said before, not because you presented the study, but because the study has the potential to be a game changer, to set a milestone in the treatment of patients with EGFR-positive disease. I can join completely what Benjamin said before and Marina said before. The issue is that I totally agree that we need to have mature survival data, because the data that you presented, the events are only 24%, and you stated that the differences in survival is not still statistically significant. Based on the data that you presented 2 days ago, I truly believe that due to the limitation that we saw using gefitinib and erlotinib in the CNS penetration of these two drugs, probably if the drug will be available, let's imagine tomorrow, I will consider for those patients that they are positive for brain metastasis diagnosis to start osimertinib in Frontline. The issue is that we need to understand a little bit more about the biology of the disease. We need to understand exactly when you will be able, the investigator will be able to completely dissect the data. What is the contribution of having a drug that is hitting the T790 mutation pretty early? And the study that Benjamin I'm just promoting what Benjamin is doing. Is doing a study in the context of a cooperative setting that is called Apple, that in addition to the 2 arms that he was mentioning before me, he has also another arm that is checking for the T790M mutation. As soon in the blood, the patients are becoming positive for the T790M mutation, they are switching from gefitinib to osimertinib. That is, at least for me, a reasonable way also to address the issue of the sequencing. Obviously, this is still an experimental way of following up our patients, but they call it clinical research. So we need to trust the context in which the study has been planned.
I would like just to add one thing, that it was my feeling when I heard the presentation 2 days ago, is that not all the centers are equipped to do the T790M. So in a certain way, if you are not working in a big cancer center or in a specialized hospital, maybe you can lose the possibility to use the drug because you are not able to test for T790M. So I think that we can discuss patient by patient, but maybe also hospital by hospital for the sequence.
That's an important issue. We need to make sure patients do get testing. So if a patient gets a first generation or a second generation inhibitor in the front line and develops progression, testing for T790 is now considered a standard workup. And if they do have T790 positivity, then in the second line setting, osimertinib was already approved based on the strength of the AURA3 trial that Dr. Tony Mock presented recently.